Welcome and hello. My name is Donna Cryer. I am the CEO and founder of the Global Liver Institute, and I have the honor and privilege of being your host for this very special episode of GLI Live. This is the first episode in our new Rare Liver Diseases series as we celebrate for the first time Rare Liver Diseases Month. For those of you who have been, part of our growth at the Global Liver Institute, you know that we have recently launched a pediatric and rare liver diseases council. And the intent of that council and this work is to shine a spotlight on the many different types of pediatric and rare liver diseases that affect so many families and communities and yet go under-recognized and underreported, and also lift up the many organizations that have been doing wonderful work for so many years with families and communities affected by rare liver diseases. And for those who have seen the logo or have been involved in the larger rare diseases community, that we want to give a shout out to and acknowledge and share our gratitude for organizations like Global Genes and the National Organization for Rare Diseases for creating the overall Rare Diseases Month and activities in which this sits. You know that zebra stripes are sort of part of the ongoing sort of theme and motto through rare diseases. So we try to combine it with our hepatic burgundy. I don't have any zebra stripes, but I did try to pull out some stripes today. So this is my sort of fashion homage to the larger rare disease community as we acknowledge rare liver diseases as part of that. So today with you to kick off this Rare Liver Diseases series, I have with me two very special people. Dr. Don Wilson is from the Cook County Medical Center. He is a pediatric endocrinologist, and he's also secretary of the foundation of the National Lipid Association. I also have with me Rebecca Trendy, who has, I think, even harder job. She is the mom of 4 boys who have lysosomal acid lipase deficiency, or LAL-D, which is the condition that we will discuss today. But as you know, it is our firm belief that the partnership between clinicians, patients, families, and patient advocacy organizations like GLI can surmount just about every challenge. So welcome to the show, Dr. Wilson.
Well, thank you very much. And just to begin the conversation, even though you talk about rare diseases, we have to remember that there are lots and lots of people who are affected, both children and adults, by rare diseases. So collectively, there are lots of people across the world that have these type of disorders. They may not have all the same disorders, excuse me, but they have something that's rare. And so collectively, if we look to organizations like yours and others, National Lipid Association, we can be a vocal presence for those individuals because they deserve not only early diagnostic tests, but early interventions that are effective. So I'm going to refer to this condition as LAL-D, if that's okay. It's lysosomal acid lipase deficiency. It's a little bit too long to say, but nonetheless, this is excuse me, an interesting disease because it affects children in 2 different ways. I should say children and adults, because the early form of this condition we see as a devastating condition, and then later on you can have other symptoms. But before we get to that, lysosomal acid lipase deficiency really talks about your body's ability or inability, as the case may be, to digest fats. Now you may think about what are we talking about here? So in your bloodstream, you have red blood cells that carry oxygen, but you may not realize that you also have nutrients. You have sugar, you have protein, you have fat, and those are normal. But those also have to be processed. So once you eat a meal or your liver makes various nutrients for you, they have to digest it and then send it out to the various cells to be processed. In lysosomal acid lipase deficiency, what's missing is an enzyme that digests the fat once it's in your body. And most of that work actually happens in the liver. So in essence, that fat is trapped in the liver. And herein lies the problem, because once it's trapped, it starts causing problems with the liver and eventually scarring. And sometimes people lose their liver function. which is important in good health and longevity. But it upsets the entire equilibrium, and so it's a multi-system disease. And as I said, in infants, it can actually be fatal. Most children, before we had some type of treatment, unfortunately didn't live beyond 1 year because it was a devastating disease characterized by a very large liver, failure to thrive, so they weren't gaining weight and weren't thriving like you expect most children to do, and then eventually succumb to their disease. Later on, you can actually have symptoms related to the disease, but it's subtle in onset. So it can occur usually before the age of 20, but sometimes in adults. It's been unrecognized. It can be very difficult for a physician even to recognize what the symptoms mean in terms of diagnosis. So organizations like the American Lipid Association, American Hospital Association, some of the other organizations that propose to try to look at these rare diseases really kind of provide both public and professional education to help us remember that this is an important disease to look for. And other things can mimic that.
I was going to say, we want to make sure that all of those resources are linked in the show notes. But in just defining the disease, you brought forward two very important points, which is one of the reasons why I wanted to feature this disease on this platform. One, so many people think that children don't get liver diseases because I think that all liver diseases are driven by behaviors and take 20, 30 years to develop. I know personally that's not true, being 26 years post transplant myself. And the other point is the centrality of the liver and its relatedness to issues of cardiovascular disease, lipids. When they think of cholesterol and lipids and things, they think only of the heart and not the role of the liver. And the centrality of the liver and its over 500 functions is part of our essential messaging. So thank you for bringing that.
Yeah, no, that's very well said. I mean, the liver, like all organs, is very complicated once you get into the biochemistry and the histology of it. Most of us sort of take it for granted, particularly when it's working. And I like what you said. I think most of us assume that children are going to be healthy, but some aren't. But every child deserves a healthy future. So it's incumbent upon us in the profession, those of you who advocate, parents, that we all work together to try to bring light on these conditions that we need better diagnostic tests for. We need earlier diagnosis because now we have treatments. We'll see how this treatment plays out, but so far it's actually performed very well. So if that enzyme is missing, then obviously after you make an accurate diagnosis, the next step is to provide that enzyme and see if the body can use it effectively. I think Mrs. Trendy can talk to that in her experience. But for my part, it's important that physicians pay attention to listening to parents, to listening to children, to having a conversation and continuing to ask the important question, what's wrong with this child? Why is this child's liver enlarged? Why is this child not gaining weight? And there are multiple resources. There's the National Lipid Association has something called Learn Your Lipids. Mm-hmm. So if parents want to know about some of these complex forms or they're having issues with their kids and they can go look it up, I think it's a very well written, very understandable kind of text that they can learn a lot and then offer those suggestions or questions to your healthcare provider. That should be an open and honest conversation flowing two ways.
So Rebecca, were these resources available to you when your oldest son, was born and you were starting to notice these signs? Tell us about your experience and how it has evolved over time.
Oh goodness. Okay. Well, Brendan was 2 years old. He's now 17. So it's been quite the medical journey for us to get through all that. But no, none of those resources were really there for us back then. That was 2006, and they had no idea what was going on with our son at all. at first it was, oh, it's just probably a common cold and he was sick and, we'll retest. And after that, we spent, I want to say probably about 2 years. We even got a liver biopsy done with him before, and even at that point in time, there was no answers whatsoever. They just knew that he had excess fat in the liver and they had no reason for it. They checked everything. Oh, his liver's working just fine. So there's no reason for it. It wasn't until probably a few years that we were just testing with Brendan that Dakota started having some symptoms, because as Dr. Wilson had said there's kind of two different diseases that go in with LAL-D, and one they kind of consider Wolman's disease, which is the younger child, the infant, and then the cholesterol ester storage, which is what they've diagnosed all 4 of my boys with. But in all honesty, Brendan was showing symptoms even before he was born, and they just didn't have any connection whatsoever. When Dakota went in, we checked his levels, and it was kind of the same thing. It was just like, oh, he's got all these same issues. So our specialist said, well, hey, let's check the other 2 boys. And that's when Charlie and Alec came into the picture. And sure enough, they all had, high liver functions. They had high cholesterol. They had enlarged livers. And that's at that point, they really started looking more on the genetic aspect. They also looked at our household as well. Like, we had our whole house tested for mold to check to see if there was something that was going on here. We sat with a nutritionist to kind of check to see if there was something in our diet that we were doing wrong. And sure enough, everything was fine. I mean, every time they did more tests, tons and tons of tests and blood work, and it would just come back to absolutely nothing. The kids were on medications for their cholesterol, and nothing would seem to work. They couldn't figure anything out. They would do EKGs and stress tests and everything on the boys, and all that showed they were completely healthy. So it was very interesting. As we progressed, that everything seemed to get normal, and we would start to research certain diseases, and it would just come up, nope, that's not it. And because you look at it, you're like, yeah, all right, that here's a couple of things that look the same, and it would just turn out to be nothing. And I want to say probably a good 4 years into looking, maybe 3-4 years into getting all the tests done, that everybody was just frustrated. And the doctors were frustrated because they didn't know what else to test for. We were frustrated. The kids were done getting poked and, tested on all these things. And the doctors finally said, let's just kind of take a break on these kids. Like, and we took a break for a few years, maybe 2 years. And from all the tests, and Dakota got sick again in 2014. And we were just kind of like, all right, our primary care doctor kind of kicked us in the butt and said, you need to get back into the specialist and get testing again. But, after going through all the tests with the kids and going through all that, it's not, as a parent, you don't want to put your kids through that again. Right. And, my husband and I, it's hard to hear the doctors telling you that they just don't know, and they don't know what else to test for. They don't know how to help you. And you kind of just feel hopeless. And I didn't want to go through it again. Like, when we were, we'd gone through it all, and they were like, okay, you need to do this again. And I was like, oh no. I mean, my husband and I, honestly, we just sat down and we prayed, and we just said, God, you need to show us an answer, because we can't do this again. Like, we can't go through this again. And we sat down with our liver specialist, and he looked over the boys, and he just said, you need to go see this other specialist. He's been working, he's a lipid specialist, and he's been working with some of the stuff. He can, he'll be able to help you. So we went and seen Dr. Macheco is our lipid specialist. Dr. Lyons is our liver specialist as well. But we went and seen Dr. Macheco, and he did a complete examination on all the boys, and he did a complete background check, like on our family health. And he just kind of said, he had actually, which is kind of a cool story, he had actually studied LAL-D as his rare disease that he had to study for his boards. I'm not sure how that part works. I'm not a doctor, but he studied that disease, and I think it's this. So he said, I want to test the boys for this. And we took the boys in, and it's simple test. It is a finger poke that you put on this little card. You just a couple drops of blood on this card. It's about the size of a business card. And they sent that in for each of the boys. And within about a week, we had a diagnosis that all four of them had LAL-D. And that was kind of like, if as a mom, after 9 years of, your kids having blood draws and liver biopsies and different specialists, that was like the biggest relief I think I've ever had in my life. Like, I just sat and cried because I couldn't believe my kids had an answer. And at this point in time, there was a treatment in the works. It was at the time, it was Lipase Alpha, I think is what the name was. And Dr. Macheko and Dr. Lyons worked really hard with the red tape to get the boys approved to be in the final phase of the trial. And I think it was about 4 months, because they had to go through all their pre-testing and stuff with biopsies and scans and all that kind of stuff, just to get a starting point before they could start the trial. In October of 2015, they finally started receiving Kanuma for the first time. So it was that process alone was the heart-wrenching time of our life, trying to help our kids and be there for our kids with no answers whatsoever. We did, after probably about 2 years of the boys receiving Kanuma, we really started to see the improvement. The boys were doing really well. And that is when we started to notice some other issues with the boys. And of course, Brendan, my ground zero patient, was removed from sports. He couldn't do sports anymore because he had this really loud heart murmur. And we found out that he has another rare defect that they don't actually have a name for. I then said, okay, look, we've been through this before. We're testing all 4 of these kids. We're not playing any games. We're just looking. And sure enough, they all had this rare defect. And they call it supravalvular aortic stenosis, but that's not what it is, because they've never seen it before. So we went through and we did more tests and more procedures and finding out all the details with that. And it just like that was kind of a hard moment, because there's no treatment. There's no, now we're dealing with a second rarity, and there's nothing for this. Open heart surgery is really the only way to fix this. And that's not really something you want to put your kids through at such a young age. Not when it's not 100% necessary yet. And to kind of explain that part is,
it's okay. We'll get
that's
wonderful
point. It's a little bit out there, but that was the part where my life got a little overstressed with 2 rare diseases. And it's actually, just for a second, that's actually not proven to be connected to the LAL-D, but with the genetic testing that we have done, it's actually also not proven that, so it is a possibility still that it's connected to the disease, because they've never seen it before, but at the same time, it's also, they don't know.
Okay. Let me unpack that a bit for our audience. A lot.
Yes, it is.
Information, and it leads me for at least 2 questions to Dr. Wilson, but let me just recap a bit for those who are following along with the story. So the time to diagnosis, is long for many rare disease patients. It certainly was in your case, 9 years, with the understandable break involved. And you talk about the different, types of testing, of blood work, of liver biopsies, of imaging. So Dr. Wilson, when I come to you, I'm going to ask sort of what the, ideal, testing would look like before you got to this wonderful, simple LAL-D test. You also talked about being referred to a lipid specialist, and your hepatologist having, the humility to do that, and that sort of collaborative spirit. And so one of the things that, we've been working on through the Rare Liver Diseases Council is, how can we support that collaboration between different specialists. I also, having served on the ABIM gastroenterology specialty board, and advocating for questions about rare diseases, and hearing some of the pushback about why do we have to have this rare disease on the test? Because sometimes somebody with a rare disease may come into your office. So I just wanted to call out that point and answer that question. How did he happen to study LAL-D in prep for his for his exam? Because someone on the exam committee fought for a question about rare diseases to stay on the exam, even though individually they may be rare, but it makes a difference. So stories like yours are important. And so I just wanted to emphasize that point about the many pieces that come together to allow for an effective diagnosis. You also talked about research and being put into a trial and being exposed to research opportunities for your family. And so that culture of clinical trial participation in liver diseases is so important for us to be able to get the treatments. Because I always wanted to say, as you were talking about the second disease, not yet. We don't know what it is yet. Maybe with more, we can. So, so Dr. Wilson, how has treatment, how has the clinical workflow and the diagnosis and management of patients changed now that a treatment is available?
So Ms. Trendy is a good example of why I love to be in medicine, because if you establish relationships with families like this, we can share not only our knowledge, but also our frustrations. And so as you continue those conversations, we kind of escalate the diagnostic test or whatever we need to do to try to get help and come up with a meaningful diagnosis and ultimately a solution. Sometimes the solutions are not the ones that we want. Sometimes they're sort of first attempts. So for example, Kanuma is just the first drug that has been developed. But once you have the first one and you have success with that, you can always refine it. But I'm at the Cook Children's Hospital, Pediatric Hospital in Fort Worth. But I've realized that there are people across the world who both need help and also who are good resources. So whereas most physicians used to have conferences or discussions amongst themselves in their own clinic, now we can actually have that worldwide with experts. So believe it or not, this is a trade secret, right? So don't let it out. But just like parents have chat groups online, physicians do as well. So when you have difficult cases, you can actually call up organizations or colleagues and sort of say, hey, take a look at this information. Now, we don't divulge any personal health information, but circumstances, and say, what would you recommend or think or suggest to me that I need to be thinking about? Because we all sort of kind of get stumped sometimes. We also sort of get in our own little boxes. In terms of diagnosis, it's critically important that not only the infants, but all people with LAL-D be diagnosed early, because even the older children or the adults unfortunately get to a point where they have severe liver disease or other organ failures, but particularly the liver. And at that point, this medication may or may not be helpful. You may actually be looking at a liver transplant or something in order to sustain life. So the earlier the diagnosis is made, the better off you are. That's just to say that this diagnosis can actually be made at birth. Why? It's because it's a genetic condition. And what's interesting about this is that both parents have this trend, this tendency for this disease, but neither of the parents are affected. It's only when those two genes come together in the infant, one from the mom, one from the dad, that you actually have a condition like LAL-D. And what you do, that can actually be just a simple little heel prick on a baby and an infant. And you can make the diagnosis through newborn screening. We do it for 28 plus genetic disorders routinely in most states. So those of us who are passionate about that, those of you who have organizations, parents, others need to try and have your people in the state legislatures take a serious look at these kind of rare diseases, particularly LAL-D, and say, we need a screening program. We need this in the newborn screening program so we can alert physicians and their parents that this child needs special attention. We would avoid a lot of morbidity, mortality, a lot of suffering, and unfortunately some deaths if we could do that early in the disease process, because now we have a treatment. We have something to offer. We can rid this poor lady of all that frustration she had to go through. Just think about the healthcare dollars that were expended in terms of all those tests. But more importantly, think about these young men that she's raising. She's got 4 kids, 4 boys. Well, they're grown men almost right now.
Almost.
But at the end of the day, they deserve to have the same type of future that any other kid does. But you got to start early. You can't wait.
So we'll definitely be adding newborn screening to the GLI policy agenda. I think our policy directors already had those conversations, but this really brings it to life, why it's so important and that it can have.
And one important point, parents sometimes get a little concerned about too much testing, particularly in the newborn, and privacy issues. We respect that. Newborn screening, as you may recall, parents have the ability to opt out if there are good reasons, if they want to opt out, either for religious reasons or whatever. That's their prerogative. For the vast majority of people, they like to know if their children are affected by any of these conditions. And you may not have an extended family history to clue the doctors in. So it really is in your child's best interest if the newborn screening test actually contains as many of these rare conditions as possible. I realize there's some financial constraints at some point in time, but don't our kids deserve this? Don't our families deserve this? Absolutely.
I absolutely, agree. I've worked closely with Sharon Terry of Genetic Alliance, who had children whose, genetic diseases she and her husband had to work to identify the gene, let alone try to organize treatments and things for. And I also have, close friends who have adopted children. So your point about not having the full medical history and wanting to be able, from day one, to be, giving them the right nutrition, getting them the right care, making sure that they have everything they need. I know that's what every, parent's heart wants. My nieces, were born with mild jaundice, and we knew about my history of liver disease, and so able to get them treatment before even left the hospital, and now they're healthy and thriving, but we knew and were able to take action. So with that information, as early as possible, parents can do what parents want to do, which is, do the best for their children and give them every possible option. So,
you don't mind if I could ask Ms. Trendy a question? Since your boys have now started on treatment, how do they feel about their treatment?
Great question.
Oh, they're doing great. They don't have any problems whatsoever. All 4 of them have a port for their IV, so that's makes it simple, and they don't have any side effects whatsoever. So they get their treatments on every other Friday, and by the time we're home, they're good to go. Whatever they got to do, when they were swimming or cross country or track or whatever, musicals and all kinds of stuff that they're all involved in, they're good to go as soon as we get home. They're, other than maybe the day of being in the hospital a little bit, it kind of, wears on you a little bit, but we're down to like an hour infusion now. So the drive is longer than the time that we're there. So it's,
well,
they're good.
That question, from a healthcare delivery perspective, certainly during a pandemic.
Yeah.
So you talked about a hospital as the setting for those infusions. Could those be done in an infusion center? Could those be done at home, particularly since they have a port? I wonder, would that be a safer option, a more efficient option, a more cost-effective option, and certainly one that.
So these are great questions because, again, rightfully so, we start in a very cautious mode because we don't know the answer to all those questions. But eventually, those questions need to be asked and answered. Could this actually be done a different way and provide the same effectiveness and so forth. But what I was really kind of after is, I would venture to guess Ms. Trendy and her family have been through a lot of emotional turmoil, also some sleepless nights, and as parents, very concerned about their kids. But I would assume that having some treatment is at least light at the end of the tunnel, right?
Oh, for sure. I mean, honestly, when we found out what it was and when we knew that there was a treatment for it, even though it was still in the trial phases, there was a hope to that, because you feel hopeless with all the I don't knows. So as soon as you hear that there's a treatment available, and I mean, when we came in, it was phase 3, so it was the end of the trial, but I think we were only on it for a few months before it was FDA approved. But I mean, at that point, they were already starting to have enough clinical study done to have the results to know that what we were kind of in for. So we knew that we were going to kind of see some of their numbers go up a little bit at first, and then we would start to see the decrease. So we kind of were prepared for some of that, but it was a relief when they got the diagnosis.
Sure.
It's so much easier now that we have a diagnosis and there's a treatment versus the 9 years of testings and the I don't knows. It was definitely a relief.
Yeah, I don't think anybody wants to hear their doctor say, hey, we know what's wrong with your child, but we can't fix it.
Exactly.
Right.
So Rebecca, I was interested in what advice you would give to people designing clinical trials. Are there ways they could have made the clinical research experience better for you and your family?
Oh, I honestly don't know if I can answer that, because I came in at the end, so it's hard to say. They had it pretty well set by the time we got in there. I mean, our nurses were so amazing there. I can't even say that they could have improved it at that point, because they took the time, they studied it, they knew we knew what we were going in for. So the boys just, and it is the same procedure now that it was before. The only thing I think the boys would probably want to see different with the treatment would be something more along the lines of maybe like an insulin pump or injection versus having to sit at the cancer center and have the infusion done. And your earlier question with the home infusions, we did do home infusions for a short period of time. With 4 in the house, it was actually much more difficult than going to the cancer center, as it puts a little bit more on mom to have to make sure everything's ordered, all the equipment's here, organized, the medicine gets out ahead of time, because it is refrigerated and has to be at room temperature. So, I mean, it put a lot more on me at that point, and it did not help me. I'd rather drive the 45 minutes to get to the cancer center from my house, and then drive the 45 minutes back and have it all done by the nurses there. So,
but I think that's a great insight. As we're defining things as patient-centric, we don't really know what that is unless we actually ask the patient, because we might come to an assumption of something is easier or more convenient when it's not actually. So
right.
That's really valuable insights. It also told us that it seemed like the informed consent and the information around the trial was well done, because you knew what you were going to expect, and it sort of matched that, and so your trial experience was positive. And so someone who helps design trials, that's really great that you experienced had a positive.
I do know that right now, our LAL-D moms that have gotten together in our Facebook group, they are working with Dr. Martin out of Cincinnati. He is working on gene therapy, which I know this is like years away at this point, but it is something that they're working towards, which would only be a one-time injection versus the multiple injections. Although, I mean, Kanuma is great, and the boys are doing wonderful on Kanuma. But I mean, it's not a cure; it's a treatment, and there's always medical advancements. And to have something that could possibly, in theory, cure our boys would always be something that would be something that we would look forward to as well.
I think that's a fantastic note for our work for the future. So as we wrap this up, let me ask each of you, to give a word of inspiration or instruction, marching order to GLI, or what do you want to most have the audience take away from our conversation and their understanding of what we need to do in LAL-D?
Well, I think for me, the fact that we now have treatment is a whole different ballgame. And so what was said very nicely, and that is that now it's just a matter of refining that and seeing what and when we can do better. We'll do better. But let me just sort of leave the audience with the idea that partnership between the family and the physicians and organizations like yours, Donna, is critically important if we're going to identify, solve problems effectively, and importantly, what Ms. Trendy shared with us is not only treat the disease, but also holistically making sure that her young boys grow up and have a healthy future.
Absolutely.
Well, for me, sorry, for me, the worst part of my journey was the hopelessness. And Brendan, first liver biopsy, stage 1, second biopsy, stage 3. We were basically at the rate that he was going, he would have been in liver failure by the age of 15, maybe even worse. And that's heart-wrenching for a parent to go through. And for those that are struggling right now, for those who are out there trying to figure out what's going on with their kid, keep going, keep trying. I know it's a hard battle, but share our stories, read up on other rare disease parents, because sometimes doctors need to be encouraged to see that zebra beyond that horse. We get stuck on seeing the basic stuff out there, and we forget about all the other stuff. And obviously Brendan is 17 now, so we've reached past that 15-year mark, and he's the healthiest out of all 4 of the boys with his blood work. So Conuma is definitely working. There is a treatment. And at this point, I would really love to see a newborn screening to prevent parents from having to go through the hardships that we went through.
We share that hope, and we commit ourselves to that work. I know my policy director and our policy work group is, we have a question that we'll answer before signing off here. What should parents do first when they have a child newly diagnosed with LD without insurance coverage?
Yeah, so that obviously comes up, but don't be deterred. There are plenty of opportunities for people who have or don't have insurance. And so you should be able to work with your healthcare provider, get contacted with organizations like yours, Donna, or others that can help them. There are plenty of ways to do this.
I've had, with dealing with some of the stuff that we've dealt with on the parent side of that, my answers to those questions, first of all, Alexion is the company that produces Conuma. They help us with what's called a co-pay assistance for that, a part of our insurance. But there's also another program out there that works directly with LAL-D families. It's called Patient Services, Inc., and they do have a website. It's shortened for PSI. They offer a lot of assistance to parents and families who are dealing with LAL-D. They even do medical reimbursements for insurances as well. So even if you went and just purchased an insurance, they would help with that coverage cost. So I highly recommend, continuing on with coverage and looking for organizations like that could help.
That's a fantastic, Rebecca, and we'll make sure to list those resources in the show notes as well. We are, increasingly working certainly on insurance coverage issues, access issues, Medicaid expansion issues, and working with with organizations like PSI and the Assistance Fund to make sure that they understand the issues of liver patients. And the specifics of reimbursements, and we also do commend the companies that are partnering to make sure that there is access to the drugs as well. So I think that this has been a fantastic kickoff to our Rare Liver Diseases series. I thank you so much, Mrs. Trendy. Thank you so much, Dr. Wilson.
Thank you.
And I hope all of you listening continue to watch the rest of our series where we'll be discussing Alagille syndrome, primary sclerosing cholangitis, primary biliary cholangitis, and certainly mention other rare liver diseases. With the information to follow us on Facebook and Twitter. Please use the hashtag RareAware as we encourage awareness of all the different types of rare liver diseases this month. And I just thank you so much for joining us today. Stay warm. Stay until next time. Bye-bye.
Take care. Thank you.